Is that okay?
Yeah.
All right, good evening, ladies and gentlemen.
Evening, George.
Good evening.
Thank you, sir. I'll just introduce myself, George. Obviously, you know me because I'm one of you guys, team member. I want to thank you guys for coming. And I just want you to note that the seating arrangements, they've been set up because in one of the units that we're doing later on this evening, we need to utilize the way the tables and the chairs are set up. So if you just kind of leave it that way, we'll be doing 2 sessions in this way, and then the third session, I'll be moving the tables out so that we have a broader exposure. Anyway, if everyone could sign in, that's apparently very important because I have to have 8 people in this process. So what am I doing? So tonight is not a SAS night. I don't work for SAS in this regard. This evening I am doing a TAFE course in training and assessment, and what I'm doing is I'm doing 3 presentations, which is required as a part of my course. So you guys are my guinea pigs to receive what I prepared for you guys, and we're being filmed, and that has to be submitted as evidence that I've done some work in this area. Okay, so everybody knows where the bathroom is, right? I just got to do some housekeeping stuff for the record, right? Everybody knows what the bathroom is. There's an emergency exit here. Please don't knock down the camera. There's another emergency exit out there, out at the front where you came in. Okay, so I like to start with the first session. So the first session, what I want to talk about is developing a provisional diagnosis, or a working diagnosis, or a presumptive diagnosis. If you read the email that I sent you, you'll note that these 3 terms all mean the same thing. And this is important to me, and the reason I wanted to bring it up is when I go to work up a patient, I want to know, I always ask myself, am I doing the best thing for the patient? How do I know that I'm doing the best job possible? So the answer for me, welcome, please sign in. For me, if I'm organized in my assessment and I have an approach, and there is an approach, and it's using clinical science, it's already predefined for us how we do this. So if I use that and I'm true to that, then I'm satisfied at the end that I've done the best that I could to figure out what's going on with the patient, right? So it's kind of like rules to the game. So if you follow the rules, then at the end, when you've collected all the information, you either know exactly what's going on with the patient, it jumps out at you, or you don't know, right? And it's okay to be in either one of those places. Where it gets tricky is when you go to apply a protocol, when you go to treat the patient. So if you don't really have a presumptive diagnosis or a provisional diagnosis in your head before you decide to treat the patient, that's ethically on a very slippery ground, right? Because we're not going to cases and going, okay, you've got asthma. Or going to a case and saying, okay, oh, you fell down and broke your arm, right? Without seeing any evidence, right? We have to collect the evidence. We have to collect the information. And the information has to tell us what's going on, especially when you use a protocol. If you don't use a protocol because nothing jumps out at you, that's okay, because that happens a lot of times, right? Cases are complicated or they're very confusing. You can't figure it out. That's okay. You just treat the vital signs and then we just take them to the hospital, right? But if we use an asthma protocol, if we use a chest pain protocol, we better have some evidence that this patient has got the chest pain. We better have looked to get that information, okay? So that's basically the introduction to doing a provisional diagnosis. So let me move to the next slide. Okay, so here is basically repeating what I'm saying. So in working up the patient and assessing the patient by asking them a set of questions, or by getting a set of observations, or by doing a head-to-toe assessment, okay, all that information should point in a particular direction. Like, does this patient have asthma? Does this patient have gastritis? Does this patient have a head injury? Things have to point in that direction. So it's based on your initial assessment of the patient and your working up of the patient. Okay, so it's also based on interpreting everything that you've collected, right? As an ambulance, I'll be speaking and addressing to the responsibilities of an ambulance officer, okay? For those of us who are not ambulance officers yet, then what this does is this lets you know what they're doing when we're on the job with them, right? And if we're working, and if we are ambulance officers, we're just reviewing what we're responsible for, basically. If you're a new recruit, I don't think we have any here, that's what's coming down the road, okay? So we have a responsibility to collect information, and we have a responsibility to analyze the information and see what it tells us, okay? All right, moving on. Okay, so after you collect all this information and you analyze it, you should have a fairly clear idea, before you employ a protocol, you have a fairly clear idea what's wrong with the patient. So if you have a patient who's having an asthma attack, all of the features of someone having an asthma attack has to be there. You have to be able to see that. You have to see that in their history. You have to see that in their physical presentation. You have to see that in their observations when you collect that information. Otherwise, we're really not practicing correctly, right? So if we have a person who is who has taken a narcotic and now they've overdosed, you have to see those clinical features before you go and give them the naloxone, right? You still have to call up and present. And that's also another interesting thing, because when you speak to the EOC and you're not clear about your facts, the person at the other end, an extended care paramedic, may just say, well, you know what, do me a favor, just take the patient to the hospital, because I'm not sure that you know what's going on, because you're not clear in your information. Okay, so back to being ethically responsible. So you need to have the facts in front of you before you treat the patient. Okay, that's really important. If you don't have enough facts to come up with a presumptive diagnosis or a provisional diagnosis, that's okay. That's what it is. If you're not using a protocol, if you're just using basic care, right, to treat the patient, that's acceptable, and you're just treating the vital signs. Okay, does that make sense? Okay. Okay, I already spoke about that. Right, so what do I mean by treating the observations? Observations, I mean as in pulse, respiration, blood pressure, temperature, BGL, SpO2, EKG. So if you have a patient with an SpO2 that's 91, what are we responsible to do?
Try and get it up again, so give them oxygen.
By giving them oxygen. So you see, we don't necessarily have to have a diagnosis of hypoxia or why the patient is hypoxic, but we see through one of our observations that the patient is hypoxic, and we're responsible to administer oxygen to bring it up to 94%. Right? Make sense? So that's what I mean by, if we don't have a diagnosis, but we still are responsible to treat the observations. Okay? All right. Now, I was hoping this was going to work. I scanned the PCR, but the information on there is crappy. So what I did was I went and got a whole bunch, and I attached the ISBAR. So what I want to do here in this exercise is I want to identify the types of assessments that we are compelled to do as ambulance officers, right? We arrive on the scene. I'll start it off. We arrive on the scene. What's the first assessment we're responsible to do?
Danger to yourself and your partner.
Okay. An assessment. A group, it's a group, right, of a whole bunch of things. What's the first assessment that every patient gets?
F3? Is that what you
Okay, that's part of it, But what's the big picture? Everybody's going to go, oh my God, what'd I tell you? Come on.
Are they conscious? Like, are they?
That's part of it. That's part of it. But what's the first assessment called? Thank you. Primary assessment. Okay, so primary assessment includes a lot of things, doesn't it? What is it? Anybody remember? AOs? DR, A, B, C, D, right? That's the primary assessment. So we're responsible to do that for every patient, right? Depending on what you find out in your primary, guides you as to what you're going to do next. So let's say you had a patient who failed their primary, right? There's a problem with their airway, or there's a problem with their breathing. Do we go on, or do we fix the problem? You fix the problem. Very good. All right. Now, another sub-assessment that we're responsible to get from the patient. What is it? In order to arrive at a provisional diagnosis. Now, I just want to tell you this. I don't know if I mentioned it, but provisional, presumptive, and working diagnosis all mean the same thing. It just depends on where you come from, right? If you come from Canada, they'll probably call it working. If you come from the States, they'll call it presumptive. If you come from Australia, they'll call it provisional. But the concept is the same, okay? I chose provisional because that's the language we're using in our work here. So, another assessment. A couple more, actually.
History.
History. Now, what kind of history, Karen?
Previous medical history.
So, past medical history. Is that what you mean?
Yeah.
Okay.
You also.
Okay, there's a mnemonic that we use. Anybody, do you know what it is, Karen? What's the mnemonic that we use to get past medical history? Thank you. All right. Yeah, guys, this is all in our system. This is not, you know, I'm not inventing this shit. This is all stuff that we do. Okay? Okay, so that's past medical history. I suggest to you that there is another history that we need to get.
Current history. So we want
Current history. Okay, so that's history
Of presenting.
of presenting illness. Anybody know a mnemonic for that one? About,
It's hard to eat, eh? Yeah,
that's right, that's right. It actually, this clinical science framework actually asks us to do it twice, right? But let's step back a little bit. So history presenting illness is amplifying what? There's one thing we haven't mentioned yet that we need to get from the patient.
What's wrong?
Okay, so what's the official name of what's wrong?
Presenting complaint?
Anybody else?
No, that sounds good.
Anybody heard of chief complaint?
Okay.
Chief complaint, right?
Same thing, it just depends on which country you come
Yeah.
from.
Exactly.
Yeah.
But I want to tell you, after reading a lot of different literature, chief complaint is the one that is used the most. Okay, and it's the one that's used in our system.
Yeah.
And if you look at the, presenting complaint is what we use here. Okay, so I'll just write presenting. All right, so what is presenting complaint or chief complaint? What is that?
What they told you for.
What they called you for. Okay, very good. All right. Anything else? Anybody else want to add to that? Okay, usually it's usually in the patient's words, right? You know, I'm having chest pain, or I feel lightheaded and fell down, or I fell off my bicycle and broke my leg, right? It's usually one simple sentence, and it's usually coming from the patient. Doesn't always have to be, but generally that's what's expected, okay? If you read the literature, that's what it says. All right, let me ask you a question. So when you do primary assessment, are you interviewing a patient or are you examining them? Okay.
Interviewing.
No, it's actually both. She's correct. Okay. Chief complaint. Is that a part of an interview or are you examining them? It's interview, right? Because you're asking them. History, present, illness. Presenting illness, is that an interview or examination?
Interview.
Past medical history. Have we mentioned everything that we're responsible to collect? We haven't, but you need to tell me what it is, because I'm not going to tell you.
We need
Come
to.
on, guys. Ambulance officers, step up to the plate. So we've mentioned the primary, which is the first thing, right? You walk in, that's the first thing you got to do, because we want to know, do we have life-threatening problems here or not, right? And then we get the chief complaint. Why are we here? Okay? So we find out why we're here. Now we're going to expand on the chief complaint, right? And by the way, the acronym we use is dollar. This system likes to use it for pain, but I can show you that it's used interchangeably for anything, right? And we'll talk about that a little bit later. And then past medical history. What else do we need to do?
Secondary survey.
Medication.
Okay, so tell me about secondary survey. What secondary what? What are you doing?
Vitals and observations.
Yeah.
By observations. I'll take observations.
Assessments.
Motor sensory.
Okay, so let's do one at a time. Okay, so observations. Now, we know what our observations are, right? Pulse, respiration, blood pressure, pupils, temperature, SpO2, BGL, EKG, right? Those are all observations. Let's go across here. How do we collect that information? Is that an interview or do we examine?
Examine.
And interview.
Observations?
Yeah, because like if they're not speaking very well and stuff like that, you're going to be asking them those questions. That comes down to being short of breath a lot of the time.
You're right, Paula. I'll agree with you because when I do my observations, I want to establish someone's mental status. So
So you're going to need to know if they've had an altered GCS as well, and that'll come out also in this.
that's right, and that's in observations.
Yeah.
Okay, but that's really the only thing. That's the only piece of information that you get by talking to the patient. So, and I'll give you as an example, and for that reason, you're correct. But you know, when you're doing pulse, respiration, blood pressure, temperature, SpO2, BGL, EKG, you know, the only communication you're having with the patient is putting it on. Please move your shirt. I'm going to stick you with a needle here. You know, you're going to be okay with that, right? But it's not getting the information, getting the data or the value. That's by mostly examination. Okay? All right, what else do we need to do? You said secondary. What do you mean by that? What are you thinking of?
Well, the motor sensory and that type of stuff.
Okay.
So like they've passed the primary, so you're happy they've gone
Yeah.
Dr. ABCDE. So you've gone, yep, they've passed that. Now we need to look at possible other reasons.
Yeah, so
So
exposure
yeah.
and stuff like that. Is that's
Yeah, that's primary. There's one more thing we need to do that we're actually responsible to do. And I'll tell you honestly, we don't do it often enough.
Patient
Go ahead.
consent.
Patient consent, no.
pain relief.
So listen, I want to do this so that we know where we're standing, okay? So this is, because we keep on mentioning secondary. So technically, within the rules of clinical science, of pre-hospital emergency medicine, this is primary assessment. That's the one when you walk in and you do DR, A, B, C, D, E. Everything else is actually secondary, okay? So, but secondary has a few components to it. And there's one component missing that we're compelled to do in order to complete this picture so that we can have a provisional diagnosis or a working diagnosis, if it's meant to be found. And I'll give it to you. It's a head-to-toe physical assessment. Okay? We're actually compelled to do a head-to-toe. And I got to tell you, you know, after 4 years, I don't see too much of that happening. Okay, there are some who will say that, look, you get called to a job, you show up, You have never seen this person before. You have no idea what's going on with them. Okay? Our responsibility is to find out. There are many who will say that the patient deserves a head-to-toe examination at least once in your interaction with them, because you never know what you're going to find. Right? If it's normal, it's normal. But if it's not, then it's probably going to be a piece of information that's going to contribute to your provisional diagnosis. Okay? All right. So head-to-toe exam is what? An examination or an interview?
Examination.
Exactly. All right. So I think I've pretty much covered okay. Yeah, and that's the reason I gave you the PCRs, because if you would have looked at the PCRs, everything that we've discussed is actually on the PCR, on that page. Okay? So just so you know, I'm not inventing stuff, right? This is stuff from the PCR, okay? All right. Does anybody have any questions about what we've talked about so far? Okay? So, this is an overview of what we're responsible for. So I'm going to connect this to what we're going to do next. So the exercise that we're going to do next is I'm going to eliminate the exams and focus on the interviews. Okay? So what we'll do next is we will do an exercise and where we can actually practice getting the chief complaint, history of presenting illness, and past medical history. Okay? As an exercise. So what do you guys think about, was this useful to review this?
Yeah.
Okay? Because, I go back to, how do I feel? Like when I go to a job and somebody's in trouble, obviously, how do I know that by the time I've concluded this job, I've done the best possible for this patient? And how I know is I follow this. Because this is clinical science. We're responsible to do this. So if I investigate all the things that are itemized here, and whatever comes up, that's what I'm going to deal with, right? If it's clear that someone's having a stroke, then I'm going to deal with the patient who's having a stroke by employing the protocol that's already written for us from our system, right? That's how it works. Prescriptions are written in advance for us, so that when we encounter the situation, we just got to make sure that we have a good idea, that we have a provisional diagnosis, and that's based on all the things that we've assessed, and then we just plug in that protocol, we treat the patient and take them to the hospital, right? There are two other elements, treat by protocol, and then of course we're responsible to reassess the patient all the way to the hospital, right? Like, we're not supposed to treat the patient, go, okay, I'm done, I'll just sit back, read my iPad, dream about something else, right? We're supposed to be monitoring the patient all the way to the hospital. All right, everybody happy? Cool. All right, let me change this.